Thank you. When we come to children, secondary glaucomas very often take away their vision very silently and they are mute spectators. In general, we need to define glaucomas very differently. Apart from, as given by the Childhood Glaucoma Research Network in 2013, children have glaucomas not only when the IOP is more than 21, progressive CD ratio is increased, or there is a reproducible field defect, but also when the corneal dia is more than 11 in a newborn, more than 12 in an infant, more than 13 at any age, or there is the presence of HAPS striae or corneal edema, or when there is progressive myopia. A patient is a suspect of glaucoma if one of these situations is satisfied. The classification of childhood secondary glaucomas, as given in 2013 by the World Glaucoma Association, defines it as glaucomas either associated with non-acquired ocular anomalies, non-acquired systemic diseases or syndromes, acquired conditions, and since after cataract surgery, glaucomas can complicate the situation at any age, it is taken as a separate entity. I'll be going through case scenarios and I'll be dealing with each of these different types. So coming to the first case, before that, coming to the incidence, it occurs in around 0.45 patients per lakh of population. According to the Big Eye study, they found that the secondary glaucomas are more common than the primary glaucomas in children. And this is also supported by many studies which have done, and each of them you can see that the secondary glaucomas are more often than primary glaucomas in childhood. This case is of a 5-month-old child of a non-consanguineous marriage who came with nystagmus and the parents complaining that the child doesn't open her eyes. On examination, the child was found to have bilateral aniridia. The cornea was cloudy in one of the eyes, IOP was high, there was a high CDR, and the patient had a high cup disc ratio in the right eye rather than in left eye. A trabeculotomy plus trabeculectomy was done in the right eye, and the patient has been followed up with timolol 0.25% twice a day for the last 5 years. The patient vision has been well maintained. The patient is using glasses. The nystagmus continues, and the child is able to attend normal school. In aniridia, glaucomas can be present in 50% of patients. And apart from the pendular nystagmus and decreased visual acuity, there could also be a corneal paleness, there could be a microcornea, there could be foveal and optic nerve hyperplasia, there could be an occasional focal cataract or lens subluxation. The aniridia in itself could be either a partial absence, subtotal absence, or they could even, some of them can even have a synechial angle closure. These patients can have an angle glaucoma at any age in life. And then when we have such patients, we should always rule out a Wilms tumor by doing an ultrasound abdomen. There can be 3 types of aniridia, those which are autosomal dominant, which are the majority, where this is an isolated condition. In Miller's syndrome, they can very often be Wilms tumors or genitourinary anomalies or a mental handicap. Or it could be the Gillespie syndrome, where it is an autosomal recessive inheritance, and these patients can have cerebellar ataxia in addition. The second child is a 2-day child who came to us with patent ductus arteriosus sent to us by Pediatric genetics, who had a corneal dia of 12, a hazy cornea, and IOP of 19. And we needed to do a fundus examination, but first we have to think, does this child have glaucoma? Yes, because a normal IOP at birth is only 12 to 16. So even a pressure of 19 is high at this age. The normal cornea at birth is 9.5 to 10.5. So a corneal dia of 12 is an enlarged cornea. We need to remember the dimensions in a newborn are very different than in adult, and remember that when we are examining our little children. The IOP increases from birth, with 12 to 16 being normal. Axial length also increases. At birth is 15 to 17. Corneal horizontal dia is between 9.5 and 10.5, as I already told you. The radius of corneal curvature also increases. The mean keratometric power of both the lens and the cornea, they decrease as the person gets older. So the patients need to be examined under anesthesia, because a crying child, even in a normal IOP, the IOP can rise up to 40. You can give them a chloral hydrate. You need to do IOP either with the Perkins or the Tonopin, to take a dia, do the refraction, because very often they could be myopics, examine the fundus for an optic nerve head cupping, which is generally concentric, take the axial length, because all these parameters at baseline can be used to follow up these patients to see whether there is controlled or not. The proxies for elevated IOP in small children, because the sclera it can get expanded, is an increasing corneal dia, increasing axial length, and a progressive myopia. So these same things can become an indicator for a glaucoma control. So a reversal of optic nerve cupping, refractive error, axial length, and corneal dia, all these three stabilizing as an indicator that the IOP is well controlled. So this child was taken up, we were planning to take up the child for surgery, but of course the child went doctor shopping, and elsewhere was diagnosed as congenital endothelial dystrophy. They stopped the timolol. The child came back to us with a pressure of 30, and in the meantime the tests had to come back, and the child had rubella. And we took up the child thanks to our setup, where we have all the theaters on the same floor, and we have the facility. The child under the same anesthesia was first operated for a PDA closure and then brought in to us, and we did a trabeculectomy plus trabeculotomy in a 14-day child. The haze improved, IOP decreased, corneal diameter stabilized, but the story doesn't end there. We need to follow up these patients very frequently and ensure that till they are at least 18 years, they are followed up, and we can, both the IOP as well as the other parameters. Cataract and glaucoma can occur in patients with rubella. This still continues to be, sadly, a common thing in our situation. And the earlier the infection, the more severe is the effect. Rubella IgM may be high. Cataract may be present. The glaucoma mechanism is due to goniodystogenesis, uveitis, and phacomorphic. There are a plethora of other eye conditions like pigmentary retinopathy, strabismus, cataract, optic atrophy, microphthalmia, mygocornea, iris hyperplasia, chronic iridocyclitis. All these may be present, as well as a multitude of systemic anomalies. So when we come to glaucoma associated with non-acquired systemic diseases or syndrome, apart from congenital, the chromosomal disorders, connective tissue disorders, metabolic disorders, phacomatosis, congenital rubella continues to be a very important cause in our situation. This third case is a lady who came to us, a child of 14 years, who was first suspected to have a CCF and had a DSA and an MRI done, and this was ruled out. Patient had high IOPs in 20s, was not controlled. There was a high CDR, and the patient had visual field defects as well. When we looked at this child, the child had a thin stature, legs were literally like sticks, there was a long, thin nose. The patient had permanent dental implants at 14 years of age. There were skeletal anomalies, as you can see in the photograph there, and fine, fragile hair. And the feet were very small. So we thought of ocular dental digital dysplasia. And this is a condition in which you can see iris atrophy and glaucoma. Less than 1,000 cases have been reported. And this patient we undertook for a trabeculectomy with mitomycin C in both the eyes. And this patient now has been following us up, but has shifted out of the country, comes at least for an annual checkup. Now, this is another child who came to us in 2013 with a nephrotic syndrome, and all of you already know the answer, what would be happening. The child had practically hardly any symptoms, pain off and on, mild blurring with only 6/12 vision, but the IOPs were sadly 47 and 55. And if you look at these fields, they are so grossly affected. This is a situation of neglect which continues to be doomed for many children. And if you look at the cup disc ratio, you can see that there is an increase. Very often we miss it out. Once we hear of nephrotic syndrome and we see the glaucoma, we say yes. But it's the physicians who need to remember whenever they are treating these conditions, and whether it is nephrotic syndrome or an ophthalmologist treating VKC, or patients who are asthmatics or with skin atopy, all these patients, we need to have the IOP monitored, see if they are steroid responders, control the IOP, choose the non-steroidal immunomodulators, and ensure that they don't lose their vision at an early age. This is the same patient who is now a young boy of 17. His IOPs are well controlled. The mydriasis, which had already occurred in the left eye, has not come back. And the RAPD still continues in that eye. The child is well maintained. Seeing the rampant use of steroids and the steroid-induced glaucoma, which seems to continue, the Indian Pediatric Glaucoma Society has undertaken to have a registry and ensure that all of us report such cases, and so that we can have all of these things reported and have a better look at it. We are also trying in the Indian Childhood Glaucoma Study Group is trying to ensure that we see how many children have glaucoma in our country, both primary and secondary. Now, coming to glaucoma associated with acquired conditions other than steroid-induced glaucomas, there is one thing which is now coming up more and more as more and more children are getting treated for retinopathy of prematurity, have good vision thereafter. They tend to sometimes have corneal haze and increased dia. So when our retinal colleagues are looking at these patients, we need to ensure that they do take the IOP, they do look at the corneal edema, they look at the AC depth and the corneal dia. There are 4 stages at which IOP can rise, either immediately after a laser these children can have angle closure glaucomas. It could be either due to the anterior displacement of the lens diaphragm, due to thermal injury, to the choroidal vasculature leading to a choroidal congestion. It could be due to a ciliary body edema, hyphema, lenticular changes, or a relative increase in the lens thickness. And in the stage 4 or 5 of ROP, when the treatment is given, or in an untreated patient of stage 4 or 5 of ROP, or they may end up with a neovascular glaucoma. And then we come to the cataract. Following cataract surgery, IOP should always be measured. And very often, even when they had a normal IOP to start with, when we are following them up, they may have a mild increase. Don't neglect this, because these children have a long life to go. Ensure that the IOP is kept under control. And this is one of our children who had undergone a bilateral congenital cataract surgery with PCIOL, with esotropia. Each of these has been looked after now, and the patient continues to be on timolol and being followed up. The glaucomas can occur at any stage after cataract surgery. Both aphakics and pseudophakics are prone. The earlier the surgery is, the cataract surgery is done, the more chances are that there will be a glaucoma in the years to follow. And if there is microcornea, again, that is a predisposing factor to glaucoma. When we have a sulcus fixated IOL, then again, you have more chances of having glaucoma. This glaucoma is more often open angle. We need to tell if any cataract surgeon who is doing a congenital cataract surgery to get the IOP checked, to get the IOP, the corneal dia taken at the time of surgery, and maybe following surgery also look at the disc, because that is the time that you can comfortably do it when the child is under anesthesia. These patients can be treated with medication, and if not controlled, by surgical glaucoma drainage devices, or the trab in these patients may not work. There are some conditions which are, as it is associated with the cataract and glaucoma, which include the congenital rubella syndrome, Loeys syndrome, and iridea and persistent fetal vasculature. And the mechanism for cataract and glaucoma, after cataract surgery in children, is that the TM dysfunction from inflammation and cellular obstruction occurs. It could be steroid induced. It could be due to the insult to developing angle structures from lens epithelial cells and vitreous. It could be due to the reduced outflow facility or developmental arrest. It could be due to the TM collapse from ciliary, a lack of ciliary body traction, and it could also be an angle closure glaucoma. So we need to monitor all these factors when we are following up a child after cataract as well. And there are many other anomalies. We will not go into details for want of time, but all these could be associated with glaucoma, and we should not lose them out. And when we are operating patients with Serge-Weber syndrome, we need to remember that they could have a very high risk of choroidal detachment in the postoperative period. Neurofibromatosis, don't think that the eyelids are covered and you can't see and nothing else is happening inside. 50% of these patients can have glaucoma. Loeys syndrome I've already alluded to. This is the other thing that we need to remember is traumatic secondary glaucoma, which Dr. Rita has wonderfully covered, so I will not be going into. Again, remember, the second most common presenting feature for a retinoblastoma, apart from a leukocoria, is glaucoma. So please do not, please ensure that you always have the retina checked out whenever you are looking at a patient with high IOP in a small child. And then this child presented to us as a perforated corneal ulcer with a large cornea in a less than 1-year-old child. This child, whether it was an anterior staphyloma, which has perforated, or it was a congenital glaucoma which was neglected and there was a corneal opacity which secondarily got infected, and now the patient is like this. And this was, I don't have time to show, but you could see the stretched out limbus. It was stretched almost to 5 mm. When during the surgery itself, it just became 2 mm at the end of the surgery. So when we are treating such patients, we need to start with medical, may need surgical treatment, trabeculotomy and trabeculectomy for the younger ones, and trabeculectomy with MMC for the older ones. And we may need to add it with other procedures. Remember, first chance of surgery is the best chance. It's more challenging than adult surgery. There is a higher failure rate. There are more complications. We need to remember the limbal anatomy very clearly, especially when we are doing a trabeculotomy. We need to follow these patients up for a long time, and it can be called a success only if a child has at least up to the age of 10, we have followed up and the patient has excellent central visual acuity, that our job was done well. Only 50% of these children reach adulthood with a vision of 20 by 200 or better. And the patient's residual vision needs to be looked after, and it's not only a challenge to the small child but also to the parent, and we need to remember that. Take-home messages is look actively for secondary glaucoma in children and ensure that these are reported. Now we'll have our registry. Give medical attention to detail while operating them. Have a good anesthesia support. High potential for complications and failure is there, but you may need repeated interventions. Follow them up till they are 18. And our goal in treating these children is the 10:10:10. An IOP of 10 millimeters for 10 years, and in patients by a surgery which will take you only 10 minutes. Thank you for patient hearing.